The main difference between cryo and radiofrequency is the size of the probe and needle. The radiofrequency needle is smaller, thinner, and it can be manipulated better, whereas the cryo probe is heavier, thicker, does not have a curve to manipulate the probe, so it requires a little more patience, little more time to do that. But on the other hand, there is so much of an advantage by not creating a lesion that will cause any damage to the nerve permanently. So we are leaving the sheath of the nerve intact, letting the nerve grow back to its normal stage without causing any deafferentation pain. So that was the biggest advantage of the cryo that we had. And at that point in time during my training, we did not have pulse radiofrequency, so there was no chance of us doing a non-thermal lesion, which came in I think in 1999 or 2000, and that is when the pulse radiofrequency was in play. But it at the same time it provided less of a duration, because the nerve is not actually damaged or lysed, and it only creates a neuromodulation type of effect in the spinal cord, whereas the cryo with the lesion is similar to radiofrequency, except the sheath is intact. So the deafferentation pain that we get with radiofrequency does not happen with cryo. What I did before was mainly we started with the intercostals, and although it was kind of dangerous, it actually left the nerve intact. And then we used to do intercostal thoracic medial branches, lumbar medial branches with cryo at that time. And later on, almost near 2000, year 2000, I started doing some SI joint. It was done in a way that we did radiofrequency at that time, with lysing the nerves close to the joint itself, not near their origin, near the foramen. So after the cooled radiofrequency came out and all the studies came out about where the dorsal branches of the SI joint are, they are done more closely to the foramen rather than more closer to the joint itself. And a larger lesion that we can form with cryo would be a big advantage for the SI joint as well. And the other things we can do for that is occipital nerve. We can do cryo lesioning of that. We can do genicular nerves for the knee joint pain, and we can even do obturator nerves for the hip joint. And definitely any peripheral nerve that doesn't have any motor function we can lyse, for example a sural nerve or any branch of sciatic nerve that is so sensory and not supplying any motor portion can be safely treated with cryo. The first one I saw was actually during my fellowship in 1994. This was a lady who had repeated radiofrequency of the trigeminal ganglion, and was done by a surgeon somewhere in middle part of Ohio. That he had done 4 or 5 of these lesions, and after that patient had horrible deafferentation pain. She was on ton of narcotics, morphine, that were not helping, and there were not too many anti-neuropathic drugs available at that time. So we had the hardest part treating that patient, and that pain did not go away. There is no limitation to deafferentation pain; it can stay forever, and the patient's life will be miserable. So in compared to that, if the patient had cryo of the trigeminal, she would not only have had good pain relief, but she would not have deafferentation pain at all. Well, my main concern with cryo is the size of the probe, for example, and if we are doing intercostal nerve cryo ablation, and if we puncture a lung, that might require a chest tube and admission of the patient. Other than that, I think there is no other side effect from cryo, because even if you lyse motor nerve, for example, the motor nerve is going to grow back. Anything outside the spine will grow back, and it will grow back without any residual deficit. So you can basically say that cryo does not really have any side effect other than the other end of the needle, which is the physician, who can cause the side effects. By placing the introducer, for example, they can damage a nerve, they can damage the lung or nearby structures. But the cryo procedure itself, if done properly, would not have any side effects. Well, I think the future definitely is bright, and we welcome the introduction of cryo again in the practice, which disappeared after about year 2000 and wasn't available for us. So after 15 years, when it is available again, I think that is a big help to the pain doctors, because now we can treat all the pain that we are worried about having deafferentation pain later on with the cryo and not worry about it at all. And they would not have neuritis, neuroma formation, because basically neuroma forms when the two nerves are trying to catch each other and they cannot find them, so they form a ball of raw nerve endings that causes a lot of pain. And then you have to radio frequency the neuroma itself. Something like Morton's neuroma, for example, in the foot, we can do that without any residual effect and take care of the patient's pain without any deafferentation pain later on.